I do appreciate the welcome I've had here in Fairbanks. People let me know that they appreciate having specialists in town all the time, sometimes with a drink at the bar, sometimes just by having my schedule booked out for 3 months. So I'm glad to be here. It's my plan to retire from here, so it'll be a long time coming. All right, so Pollen to Pot Roast, a whirlwind of allergy. This is the summer lecture series, so I figured I would try to talk about summertime allergies and cover things that could happen in Fairbanks or could happen to people from Fairbanks while they travel. And pot roast is maybe a stretch, but it's one of my favorite topics, so I try to cram that in every talk I have to give, and we'll get to that a little bit later. So I hear nowadays you hashtag stuff. So the hashtags are the other titles I gave this for Allergies Don't Take Vacation and How to Ruin a Picnic. I don't have any disclosures. Nobody pays me to do anything. I mean, like talk or for a drug company or anything like that. That's never really been too much of an interest for me. I'd rather have a dinner with my family than give a talk for a drug company. We'll cover a few topics. Start with allergic rhinitis and pollen allergy, the very basics. You know, Fairbanks is famous for its birch pollen counts, so birch is king around here. We'll have some pictures of birch pollen and a little bit of talk on that. That blends right into oral allergy syndrome. Oral allergy syndrome, I see that 10 times as often here in Fairbanks as I did in Georgia. Oh, wrong one. Did I do it? Oral allergy syndrome. Again, I've seen it 10 times as much in Fairbanks as I did in Georgia, so there's something about those high birch counts that make that come to fruition. Then peanut allergy, I chose that because in just the past 5-6 years, there's been major changes in how we address peanut allergy, methods for preventing peanut allergy, and a 180-degree turnaround from what we were recommending and saying before. So when we used to tell you the wrong stuff, we need to make sure we get the word out there when we're telling you the right stuff now. Alpha-gal allergy, that's my pot roast. That's my favorite topic. We'll cover stinging insects. I call them all bees. That's just the Georgia in me. They're all bees, but we'll have a little bit about each of the bees. And then there's no fire ants in Alaska, but there's military up here. And we have people who travel to the southeast United States and come back with fire ant allergy. And then lastly, wouldn't be summer without sunshine. So we'll have a few examples of sunshine allergy, so to speak. I didn't know if we needed objectives or not for this type of lecture. When we gave them at the medical college, we always had objectives. So I made some simple ones. Understand some of these summertime allergies. Maybe know some basic treatment options for allergies. Same thing applies whether you're talking about pollen allergy, environmental allergies, food allergies. There's really a few basic approaches. And then you'll be maybe better equipped to travel with these allergies, at least know what you could be getting into at different times of year in different areas. And how I presented this was a series of scenarios or examples of what might happen. You might recognize, most of them are 70s music references. So we start off with Mungo Jerry. He's an 8-year-old little boy from Anchorage, but he got to come up at spring break and spend some time with his cousins, and that was so much fun. But there was snow on the ground, and so they didn't get to go out in that side-by-side. So the older boys promised him they'd take him out on the side-by-side the next time he came back, and he's getting to come back this summer. So just as promised, they took him out in the side-by-side, but then only about 30 minutes later, his eyes were swollen and watering. His cousin saw that the white of his eye was swollen over, overlapping with the iris, and he got scared. So they drove straight back home where his uncle made him drink Benadryl right out of the bottle. Didn't even know how much it was, just drink some Benadryl. And a few hours later, he was asleep when he could finally stop rubbing his eyes. So his weekend was over before it started. And this is May in Fairbanks right here. We see these eyes 3, 4, 5 times a day in clinic. And so this was in the month of May in Fairbanks, Alaska. It's not always, but it's almost always the birch pollen. Oh, these eyes, sorry. I don't know if you can see the conjunctival swelling over the iris. That would be called chemosis. The first time you see that as a parent, it is pretty scary. The first time you see it as a clinician, it's pretty scary. You've only seen pictures of it, but when those first eye, it looks like it's just, you can almost not make out the color of their eye because it's so swollen. It is pretty scary. So we would attribute that to birch pollen. The birch trees are abundant here. Dr. Foote, who retired and I replaced him, he did research papers on the birch counts in Fairbanks, so he was published by just putting out the high numbers that we experience here. That's an electron microscope picture of birch pollen. In training, we had to identify pollens for our boards, and we were always told that those look like little teddy bear heads. So if you saw a teddy bear, it was birch pollen, and it was springtime. And it would probably have some cross-reactivity, which we'll talk about a little later when we get to oral allergy syndrome. As you move out of spring and into summer, it could very well be the grass pollen. Wild grasses are pretty much all the same when you look at their pollen. We used to say that the grass pollen looked like the Death Star from Star Wars. And certainly we have some issues with grass here, but in the southern United States, you have almost a year-round grass season, and the grass counts can get pretty high. So it was aptly named the Death Star. As you move into the fall, let's skip one. There's not a delay, it like hits it twice. Ragweed pollen. So in the Midwest, in the East Coast, ragweed is king. They have a fall season like we have a birch season. They have 4 to 6 weeks of misery. In Minnesota, it started right around the first week in September. And then aptly, I think the ragweed pollen looks like the end of one of those maces that you'd swing around to smash somebody in an old-time joust or something. The other pollen that kind of is name-worthy, and we do test for this here, is going to be the mugwort. And particularly show mugwort because later on with oral allergy syndrome, mugwort has its own famous scenario called mugwort celery spice syndrome. And so I just wanted to show a picture of that as we went through the pollens. But with our sky high and very short window of time in the spring, birch deserves most of the attention in our discussions here. All right, so every day we talk about this with almost every patient. You have allergies. What can we do about that? And there's really, I say there's 3 basic things. One, you can avoid what you're allergic to. If it's a food allergy, that's really the only treatment. You're allergic to peanuts, don't eat peanuts. But that doesn't go as far when you talk about pollen avoidance. How can you avoid birch pollen in Fairbanks? Pack up and get the heck out for a month? I mean, that's about the only way you could avoid it. So maybe you do take that trip to the beach in the month of May because it's so miserable. But avoidance goes a lot farther for food allergies, maybe further for environmental allergies when you talk about pets, when you talk about dust mites. But maybe seasonal allergies is where it leaves us desiring the most from the other angles of treatment. So you can avoid it. You can try to cover up symptoms with medicines. And admittedly, allergy medicines fail us a lot of times. There's only a few different categories. Most everything is available over the counter, and I've outlined them here. So antihistamines, histamine being a driving chemical factor in the allergic reactions going on in the nose and eyes. So there's kind of 2 categories. First generation, that's going to be your diphenhydramine and your Benadryl. Those tend to make people sleepy. They tend to be very short-lived in their activity, maybe 4 to 6 hours. And so they left something to be desired. And then about 25 years ago, a whole new wave of antihistamines, the second generation antihistamines came along. Loratadine, or brand name Claritin, was probably the first one to get name recognition. And so it's kind of a go-to for a lot of people. But there are kind of 4 main ones on the market. Generic names are cetirizine, levocetirizine, fexofenadine, and loratadine. They're not going to make you sleepy. But if you're an airline pilot, you can't take cetirizine or levocetirizine. You'll have to take fexofenadine or loratadine because the FDA allows them to claim to be non-sedating. There's one other category of medicine, It's a leukotriene receptor antagonist. So instead of histamine, it interferes with the activity of leukotrienes on their receptor. And there's really only one medicine in that class that survived, and that's montelukast. It's prescription only, so you can't just go to Fred Meyer's and pick that up. And it has recently had a black box warning placed on it about a side effect profile, which involves affecting mood and causing nightmares. I've used it in thousands of patients, but I've had 2 children who would sleepwalk when we put them on montelukast. So, there's no perfect treatment out there. Nasal sprays come in 2 forms: nasal steroid sprays, nasal antihistamine sprays. Nasal steroid sprays would probably be considered the gold standard in the textbook. The way they work, they theoretically could be the most complete, but they have to be used the right way. They kind of have to be used before the fire's blazing. So nasal steroid sprays are great at keeping fires out, but not putting fires out. In Georgia, I told patients it's Valentine's Day, don't forget your sweetheart and start your nose spray. Fairbanks, Alaska, I say it's April 15th, you better pay your taxes and start your nose spray. So we got about a 2-month later start to the spring here than we did in Georgia. Nasal antihistamine sprays are a little bit more on-the-spot treatment. There's an over-the-counter brand or generic azolastine, and there's a prescription olopatadine in that category. Those can help you maybe get a little bit more quick relief, and when added together with the nasal steroid spray can help congestion better than either one alone. And then lastly, I got one eye, so I always make sure my patients have an eye drop on hand for as-needed use. And they kind of go from Napthcon, which has been around for years and years, to Ketotifen, to the newer olopatadine, which you might see is the same ingredient that's in the antihistamine nose sprays. Those are all available over the counter now, so you don't need me to fill your weapons chest up with those medicines, but you might need some discussion on exactly how to use them, such as making sure your nasal steroid spray is started well before the season. But the whole field of allergy is designed around knowing what you're allergic to so you can avoid it or you can manipulate instead of using medications to cover things up. So what else could you do? You could try to desensitize yourself. If you weren't allergic to what you were allergic to, you'd probably be better off. So there are several ways to do that. The most kind of standard one that everyone knows about would be subcutaneous immunotherapy, or SCIT, also known as allergy shots. That's where you literally come in and get a shot of the stuff you're allergic to over and over again to retrain your immune system to not be so reactive to it. We use that for pollens, we use that for animals, we use that for dust mites, we can use that for molds. That's the gold standard treatment for bee sting allergy and fire ant allergy that we'll talk about in a little bit. That's got a long track record. But the wave of the future, all the craze in Europe, is SLIT, which is sublingual immunotherapy. So you don't have to come in, you don't have to get a shot. You get to do this at home by putting drops of allergen under your tongue every day in the comfort of your own home. There are commercially available prescription tablets for some allergens like ragweed and grass, dust mites. Those kind of came onto the scene and didn't catch on too big, so it's not easy to get those through the pharmacy or through your insurance. What is caught on a little bit better is seasonal SLIT. So this is sublingual immunotherapy that you do based on what the season is. We do this in our clinic for birch heading into the spring. So the whole month of April, we give out birch pollen drops for patients to use under their tongue at home. You got to get a head start on the season, just like with the nasal sprays. So 1st of May is too late to start them, and we throw out the rest of the supply. So you got to pick them up in April if you want to do them. This is used other places for ragweed. There's other versions of it. There's lymph node injections done before the season. That's a little bit more of an aggressive way to do it. But patients in Fairbanks who have tried the SLIT absolutely love it. And so I think we did 250 patients on SLIT this year. And if I look around Fairbanks, it maybe should be 2,500, if not 25,000. So it's a very natural treatment, and one that I encourage for the people miserable in the spring. And then lastly is multi-allergen SLIT. I don't have the capabilities at the clinic to make that, where we could do the same under-the-tongue treatment for cat allergy and birch allergy and dust mite allergy all wrapped up into one set of drops. but it is available at some clinics throughout the country. It's not a FDA-approved use of the materials yet, so it's like something that patients have to pay for out of pocket. And so that hinders it a little bit. You also have to have the materials and the processes to produce the multi-allergen slit. I did provide that for my patients when I owned my own clinic in Georgia. So avoidance goes so far, cover it up with medications, and desensitize yourself. That's how you can approach seasonal allergies. That's similar to how you can approach environmental allergies and food allergies. And that's going to bring us to the oral allergy syndrome. So this is the Osmonds. Do you know these twins, Donnie and Marie? They were growing up in Fairbanks, and they both had severe springtime allergies. Springtime allergies. So all Donnie had to do was make it through May, and he'd be all right. But Marie got the short end of the stick because she seemed to get the food allergies that go along with it. I mean, she prided herself on healthy eating. She used to love a crunchy apple every day, but all of a sudden apples started to make her throat itch. It made her tongue feel funny, and she had to stop eating fresh apples. Shortly following that were cherries and peaches and even fresh carrots. She became growingly frustrated with avoiding these favorite foods of hers, these fruits and vegetables. But then, one bad apple don't spoil the whole bunch, girl. So as she was snacking on some trail mix with some raw almonds in it, she had a little bit worse of a reaction. It felt like the roof of her mouth was closing down on her throat, and it was a little bit scarier than the other reactions she had had. She just wondered what food would be next. So this is the oral allergy syndrome that we referenced a little bit earlier. This, her example is what we see in is what we see with the birch around here. Now, usually these reactions are mild. They're not anything to be terribly afraid of. I mean, they're uncomfortable, and they scare an individual a little bit because it feels like maybe your throat is closing. But almost universally, they're limited to just irritation of the mouth, lips, tongue, maybe a little bit of the throat. There are very rare occasions when it can extend to a little bit more of a reaction, and that's where the tree nuts, they scare me a little bit more because tree nuts are standalone, kind of notorious for more dangerous reactions. So once you start reacting to the hazelnuts and to the almonds, we kind of respect that a little bit differently. So this is just a general pattern of the main cross-reactivity we see, birch, ragweed, and mugwort, but grass pollen also has a cross-reactive pattern with legumes and some of the grains. So remember we saw the birch pollen earlier. It's like if I hit it once, it goes twice. But you will see this with the fresh fruits. Apple birch is the prototype. That's the one that's described in all the textbooks. If you're taking a test in medical school, certainly they'll use apple as an example. But any of the pitted fruits seem to cause problems. Peaches, plums, pears, cherries, apricots. You know, I haven't had apricot, I don't think, since I was a baby, so that one wouldn't bother me too much. But I have people who love apricots. Almonds and carrots might be the one that would get me the most upset. I've had patients who didn't care about their seasonal allergies. They just wanted to eat apples again. And so they would do allergy shots to desensitize them to the underlying birch allergy that's really behind the apple allergy. When you test patients with oral allergy syndrome or pollen food allergy syndrome, the tests are usually negative for the fruit that bothers them so much, but the test is positive for the pollen. I've had patients who say, I'm not bothered by the spring at all. I don't need medicine, it doesn't bother me, but we test them, they have a vibrant reaction to birch and a negative test for apple or peach or pear, whatever was bothering them. So, it just goes along with the theory behind it that it's birch, not the actual fruit allergy. Then the grass pollen, like I said, that it would make sense that grass pollen might cross-react with corn or with wheat or with soy. I see legumes cause a problem in some grass allergic patients. I've seen legumes like beans and peas cause digestive issues in people who are extremely sensitive to grass pollen. So when we evaluate for chronic digestive issues, sometimes we'll do a very smattering of pollen tests to see if maybe we can blame some of that digestive issues on the cross-reactivity. So an inflammatory response in their gut because they're sensitized to grass. Ragweed, also notorious. These are the fruits such as cantaloupe and watermelon, honeydew. So somebody is complaining about that allergy, zucchini allergy. There again, you hear it, and you know it's unlikely to be an anaphylactic type allergy, but they probably have ragweed behind it. And this is where it all starts to blend together because these same foods can cross-react with latex and cross-react with each other, and they can cross-react with peaches. And so it is a tangled mess when you really try to get to the nitty-gritty behind pollen food allergy syndrome. But as I was saying before the talk started, I think I've seen this 10 times as often in Fairbanks as I did in Georgia. And then mugwort gets mentioned. We test for mugwort here. It's not the most problematic weed in the fall, but it is present. It does pollinate. And it is famous for mugwort celery spice syndrome. And you can see that if you look across, most of what is noted there are spices, but also bell pepper, mustard, and the broccoli cauliflower kind of family. So again, when you hear the story of these food allergies, these aren't the most usual standalone food allergies. If somebody has broccoli allergy and they don't have an egg allergy or a peanut allergy, they don't show that they have the tendency to food allergy, you're probably dealing with pollen food allergy syndrome. Which brings us to the third scenario. This is Richie Valens. He's a 4-year-old little boy, and he's headed to the lake with his family for a picnic. Oh, we got ahead of it. He's got 2 older cousins who are very, very allergic to peanut. And because their mom's sister, she was scared by this. So she didn't let peanuts in her house. And now that he's 4, he's old enough. I mean, when she was little, the allergist told her parents not to give her peanuts till she was 4. So she did that also. She's only recently let him start enjoying peanut butter and jelly sandwiches, but really, he only takes a bite. He doesn't even finish it. He's very excited, however, about the peanut butter pie that Mom's going to bring to the picnic. He can't wait. It's covered in whipped cream. But then, about 5 minutes after he takes the first bite, all the music jokes go right over your head when it skips it. La Bamba. About 5 minutes later, he vomits all over the picnic blanket, and then he just wants to go home. He's not swelling yet. He's not breaking out in hives. He wants to go home. So sometimes a 4-year-old, a 2-year-old, when they're having an allergic reaction, they just don't feel right. And so they do something like, I want to go home, or they just curl up next to their mom. And then 5 minutes later, that's when you see the hives and the lip swelling and the kind of the full allergic reaction. So this gets us more into the important food allergies like peanut. And why is it important? It's important because of the impact on healthcare. It's important because these can be life-threatening reactions. It's important because of how many people they impact. But a food allergy is a variety of different pathophysiologic mechanisms. We're going to focus on IgE-mediated reactions, particularly peanut, and in this talk. I'm not going to get into all the food allergy. That was a talk 2 years ago. Well, I'm hitting the right button, right? So 6% of children listed with a food allergy. It's more common in kids than adults. Almost 2% have peanut allergy, and this number has tripled over the past couple of decades. This is where we'll talk about here that actually the field of allergy was causing peanut allergy by telling people to not feed children peanuts until they're 4 years of age. We particularly were telling that to children who were siblings of other allergic kids, or kids who, as infants and toddlers, demonstrated other types of allergy like eczema. And we were withholding peanuts from the exact group that would benefit from eating peanuts. as shown by some of the more recent research. So if you ask somebody if they have an allergy, they're much more likely to say yes than if you prove whether or not they have allergy. So about 4 times as many people claim a food allergy as have gone through the steps to prove it with testing or ultimately an oral food challenge. In kids, milk, egg, wheat, and soy are the most common, but the peanut, tree nut, and seafood are the ones that will persist. Those seafood and tree nut are the more likely ones to show up in adulthood. Another reason it's important, like I said, is that people die, children die from food allergy every year. You might think little kids who would reach up and grab something they're not supposed to get or not know what they're supposed to avoid might be more likely, but it's actually the teenagers and young adults who don't pay attention or risk take that might be more likely. When you hear about it in the news or online, it's usually, a college-age student ate some cookies, they didn't know what was in it, they didn't have their EpiPen, or they didn't know where it was in the dorm room, and one thing led to another. But we do know that there are some connecting factors between the bad outcomes from anaphylaxis, and those are teenagers with asthma, and then when there's a delay in administering the first dose of epinephrine. So the treatment for a food allergy is don't eat the food, but the treatment for an allergic reaction from a food allergy is epinephrine, epinephrine, and epinephrine. And even if the first dose doesn't stop the reaction and fix everything, there's something about getting epi in there and stopping the cascade of events in some fashion, or at least hindering it early on, that keeps the reactions from becoming the more severe, life-threatening reactions. So peanut is by far the most common food to cause fatality, followed by tree nuts, and then you get some milk and seafood in there. Again, we talked about how it's tripled over the past, over a couple of decades, the prevalence of peanut allergy in children. And that leads us to the LEAP study. So another reason why it's important is a burden on quality of life. This affects families. This affects families planning vacations. This affects families planning dinners. This affects children going to school. They're more likely to homeschool. They have lower self-esteem. There's all kinds of studies that measure the impact of just food allergy on children growing up and on families. That brings us to the LEAP study. So somebody had a great idea and just wondered why there's almost no peanut allergy in Israel. And they said, well, how would we figure out if there's something special going on in Israel? And so they found Jewish children in the UK, and they measured peanut allergy in them, and it was 10 times as high. And they're like, well, why is it so different? These kids are the same. So they ratcheted it down. They did studies to prove that there was no difference between the kids. There's no difference in their tendency to allergy. There's no difference in social class, genetic background. Even the peanuts were the same. They did research on the peanuts in the UK and Israel. And there was no difference that they could be attributed to except for La Bamba. So in Israel, all the kids eat these Bamba snacks, and in the UK, they don't. So they designed a study around the ingestion of these snacks in the UK, and were able to prove that feeding babies peanut prevents peanut allergy. We won't go into too much of the detail, but they took almost 700 kids. They tested them first. If they were violently allergic to peanut at the start, they were excluded. And then they put them in 2 groups. So they either started off with their skin test showed they were allergic, and then they told them don't eat it. Skin test said they weren't allergic, and they told them you have to eat it every day. Or they had skin test negative, and they were put in one of those 2 groups. So 4 groups. Started negative, ate it. Started negative, avoided it. Started positive, ate it. Started positive, and avoided it. And if they started with a positive test and then they avoided it because they were worried about being allergic, almost a third of them ended up allergic when they did a peanut challenge at the end of the study. The whole opposite end of the spectrum, if they're negative skin test and then they ate it every day, they only had about a 1.9%. Now, that sounds high because I just told you about 2% of kids, but these kids were set up to be allergic. These were children who had eczema. These were children who had other food allergies, specifically egg allergy, heading into it. So they were at a much higher risk to start. But in the end, it protected against the development of peanut allergy tenfold. So the new recommendation, this is of 2017, is that if you have a child with eczema, so showing early signs of allergy, we need to introduce peanut into their diet between 6 and 12 months of age. If there's a child who's already shown other allergy like egg or milk, we want to introduce peanut into their diet between 6 and 12 months of age. With the Bomba snacks or with watered down peanut butter, you know, a 6-month-old can't eat peanuts, and they really can't handle thick peanut butter. Like I hear, if you were going to break into a house and there's Doberman pinschers, you give them peanut butter, and it takes them so long to eat it that you can get away with all the goods. And maybe I saw a Muppet movie with that one time. I don't know where I am in the backtracking. Isn't working? Mm-hmm. It's perfect on my screen. He just wants to jump past that one. So it becomes important to diagnose a peanut allergy or a food allergy accurately. And that just goes back to how we do that. We take a good history, and the story usually dictates the answer. Testing for food allergy should be directed by a history. If you randomly test for a bunch of foods, you get false positives. You mislead people into avoiding foods they don't need to avoid. So history is king. The story should say that you're allergic to a food before you go and test for a bunch of foods. Now this is hard to do sometimes because people come in looking to have a panel of foods and be told what they're allergic to. But that just doesn't hold up as very accurate. We do know that there are some main foods that make up food allergy: milk, egg, soy, wheat, peanut, tree nuts, fish, and shellfish. And those were called the Big Eight. Congress passed some laws about food labeling, which we'll show real quick here. And the Big Eight became famous that way. Well, as of the first of the year, there's now a Big Nine, and sesame has been added to the list of foods that must be labeled correctly. Again, this is that history is king in trying to determine a food allergy. There's a lot more detail there than I think will go with this talk, so I'll try to skip through the history if it'll move. There we go. I don't know. I mean, it's going back and forth or what? Well, if you can go to one, the next one has pictures of skin testing. Yeah, there we go. Proving a food allergy, skin testing can support a story, and that can make a pretty definitive diagnosis. But ultimately, disproving or proving a food allergy is done through an in-office oral challenge, where people will eat the food under observation, and we prove whether or not they're allergic to it. The skin testing can guide that. Blood testing can give you extra supportive information on the risk of those challenges. Blood tests can give you some extra details also. As an example, a skin test is positive or negative for egg. But if the blood test is over 7 in a child over 2, they're 95% likely to react if you were to give them that food. So blood test sometimes gives you more detail. Also, a negative blood test is the most accurate at ruling out a food allergy. So a skin test can give you false negatives, and a blood test can give you weak false positives. But ultimately, the treatment for a food allergy is do not eat the food. Just like the treatment for cat allergy is don't have a cat, and the treatment for birch allergy is to avoid birch. 100% avoidance is not very easy because of several situations that arise, including cross-contamination. Cross-reactions first. Cross-reactions where foods are very similar. We see this amongst the family of tree nuts completely, but within that there are some twin brothers. Cashews and pistachios almost always react together. Pecans and walnuts are almost always reacting together. If you're allergic to one shellfish, you pretty much have a high chance of reacting to any other shellfish. It's a little bit different when you get to the fishes. You can be allergic to one fish and not another, a lot easier than one shellfish and not another. In general, people aren't allergic to seafood unless they have more than one allergy. You're allergic to shellfish or fish. Cross-contamination. That's where somebody has a reaction after eating a hamburger that was cooked on the same grill as shrimp. Or notoriously buffets where you eat and use the same scoop in different foods, especially like at a Chinese restaurant. You always hear in the news about a kiss from a boyfriend causing an allergic reaction in somebody allergic to peanut butter. Those are exaggerations and those are hyperbole. And then eating carrots grown on an ant farm is not true. That's a joke. Never mind. Sorry. Makes me. I love this system here. All right, so traveling with food allergies. That's why it's so difficult to travel with food allergies. You have cross-contamination, you have cross-reactivity. Add in that you're traveling to a country where you don't speak the language, and there's a lot of things you need to do to prepare for one of these summer trips. So long before you go, you want to have as clear understanding of what you're allergic to as possible. And that is done through testing, through food challenges, so you can know the truth about what you're allergic to and avoid it. You need to know how you would treat your allergic reaction. You need to make sure you're familiar with how to use an EpiPen, not just that you carry your EpiPen. You need to know that you can bring your EpiPen on the airplane. You might need a letter from your doctor depending on where you're flying. So there are things to do to prepare before you go on a trip. Yes?
Could you explain that one statement? You can be prepared to deal with the reaction on the road if you are not prepared to deal with it at home.
Right.
And that sounds more type of strange.
And
That's not it. That's not on that.
so if you're not ready to handle an allergic reaction in your own home, then you're not ready to handle it when you're on an airplane or when you're in Germany or somewhere else. So you need to know the basic approach to your reaction. You can
be prepared to handle allergic reaction on the road if you are not.
Oh, you cannot. Sorry, that's a big typo. I should say cannot, yes. So the point being, you understand your EpiPen, you understand what you're allergic to, you understand your food allergy action plan before you travel, so you're not figuring it out while you're trying to talk to a policeman who only speaks a foreign language. When you plan that, you should ensure that you have multiple EpiPen injectors with you. Confirm that they're not expired. Expired EpiPens don't turn to poison. They're still good, but you'd rather have the best guarantee that it's going to be effective if you use it. They've done research. 10-year-old EpiPens still have about 40% effectiveness. It's a linear degradation to that point. So if you have nothing but an expired EpiPen, you'd use it. If you're picking your hotel, maybe one where you can prepare your own food when you need to. It has a kitchenette would be helpful. Bring some food that you know you can trust and eat that's non-perishable. And if you're going to a foreign country, and there's a website that translates food allergy placards into 50 different languages on various foods. And I have a little handout we give to patients in that situation. These are just completely off. So learn the words written and spoken for your food allergy. Have a comprehensive list of ingredients. With the new labeling laws in America, it has to be named by its name. You can't call milk casein. You can't call milk custard. You have to call milk milk. But that doesn't hold true in other countries necessarily. And there's a slide where it shows labeling on the map here, how different it can be. Translation cards or chef cards that are very simple. Peanut makes me sick. Eating food that touch peanut is dangerous for me. I'm allergic to peanuts. Very simple statements of that to carry with you when you travel abroad. Pictures of your food. Translated copies of an actual food emergency plan. And again, there are websites to help you build this, which I have a quick slide of here in a minute. They actually did a study where they questioned 1,300 people about food allergies on an airplane, and they found that if you do these 8 things, you will be less likely to have a food reaction on an airplane. Request anything, just to say, I'm allergic to peanuts. In any way make that a statement reduces your risk. Requesting a peanut or nut-free meal wiping down your countertop, avoiding airline pillows and blankets so you don't get leftover allergen from somebody else, requesting a peanut-free nut buffer zone, and this is a requirement on flights through Canada, and then not consuming anything that they provide you in case there's cross-contamination. But those 8 things absolutely reduce the risk of reaction. Now, a reaction on an airplane happens about 1 every 12.5 million passengers. So the fear of cross-contamination within an airplane is a little bit overblown, but it might be the fact that it's overblown that makes that number as low as it is. So this brings us to the labeling laws. These are the big 8. And so what Congress did is they said, why are people dying from food allergies in the emergency room? And they reviewed 30,000 emergency room visits for food allergy, and there was 150 fatalities per year when they looked at that. So they said, we've got to do something. So they set out to do some research, and they went to Minnesota and Wisconsin. I don't know why they picked those states. And they said, all right, you tell us that there's no eggs, there's no peanuts in these foods. And then they actually investigated the food, and 25% of the time, those foods were in it when it was labeled to be peanut-free. So they said, obviously, we have to make a law about this because people won't do the right thing if 25% of the time it's wrong. So that's when they passed the FALCA, the Food Allergy Labeling Act, and they have to be very clear on labeling 8 major allergens. Again, it's been updated to 9 major allergens as of January 1st. And the label has to clearly say. So it either has to be in bold print within the ingredient list, and it has to be called milk, it has to be called egg, it has to be called wheat, it has to be called soy, or underneath the ingredients in a special place it has to say contains the food. So learning how to read a label is important for food allergic patients. But then when you go to other countries, it could be very different. Different labeling laws. Some require more, some require less. But you can see where you go, it could be very different. Again, all the more reason to prepare yourself with all your resources. This is a worth its weight in gold handout for patients and children when they're traveling. The Equal Eats website that will translate the cards into 50 different languages. The Food Allergy Research website, that's where we send everybody with food allergies. That's run not by parents of allergic children. Allergy Travels Facebook page is a group that's very accurate and very factual on their advice. So these resources are priceless for patients when they're traveling. And then I always have to throw in food-dependent, exercise-induced anaphylaxis, because it's so bizarre. You can eat a food and not react. You can exercise and not react. But if you eat a specific food and then exercise, you can have an allergic reaction. That is much more likely, I think, to happen in the summertime. And so it needs special attention in the summertime allergy lecture. It was originally described with celery. There was somebody who turned over a new leaf and was going to exercise every day, eat healthy, and then anaphylaxed because of that. I think that's just like the most unfortunate outcome they could have expected. Finally, another scenario. Trent's old Army buddy Brad is coming to Fairbanks for a visit. He's stationed down in South Carolina for the past 3 years. And they're going to get together and have a good old time. You know, they're 2 avid hunters. That's why they hit it off in the first place. They're steak and potato kind of guys, and they're going to come up. He's going to show them the town. They're going to go to the Turtle Club and eat. So after their night on the town, they are full as ticks, pun intended, from the Turtle Club, and they turn in and go to bed. But then at 5 a.m., Brad wakes up feeling like he's on fire. He staggers over the light switch, and when he turns it on, he's covered in hives, and his stomach is just painfully crampy and bloated. He feels like his throat's closing down a bit, and he can almost hear himself wheezing. He's having a full-blown allergic reaction. And Brad Paisley, I guess, has a song, I Want to Check You for Ticks. I've never heard it. That's the only song I haven't heard on here. So what's he dealing with? He's dealing with this alpha-gal allergy. This is one of the newer allergies. It's the way they came upon the discovery of it just amazes me. But I've seen Dr. Platts Mills talk at allergy meetings, and he's about the smartest man in the world. But him and his colleagues at the University of Virginia were dealing with some fatal allergic reactions to a brand new experimental monoclonal antibody, cetuximab, and it was the first exposure. In theory, you can't be allergic to your first exposure to something. So why were these people having these severe anaphylactic reactions? Well, at the same time, another colleague said, you know, I've been seeing a lot of new meat allergy in patients. That's not a very common allergy, and all of a sudden, I've got more red meat allergy than I know what to deal with. So they put their minds together and they identified the allergen. It's called galactose alpha-1,3 galactose. It's a very different allergy than most allergies. It's not a protein allergy, it's an oligosaccharide. It's an oligosaccharide, which is much larger structure, so usually not very allergenic. Reactions occur well removed from when you eat the food. So unlike peanut allergy, which will happen like it did for that little kid within minutes, this can happen 4, 6, 8, 12 hours later. So the prototypical story, the story you'll have on a test in medical school will be, you know, a hunter has a big steak dinner and goes to bed fine and wakes up 8 hours later having a horrible allergic reaction. So it goes further than that. A statistician then said, you know, these reactions are happening in the same area where the Lone Star tick is endemic. And they were actually able to tie in that a bite from the Lone Star tick was triggering the conversion to make people allergic to this alpha-gal antigen. So, you know, great minds came together and figured that out. And now we know to look for that in all kinds of different settings. People with recurrent hives, people with chronic abdominal issues. It can be drawn back to this tick bite. We don't know exactly why it happens, though. So there's theories. It's something natural in the tick's saliva. Some people theorize, well, the last meal was on a cow. They were sucking the blood on a cow, and then they bit the human, and so there's some residual something that triggers the allergy. Or, like many other tick-borne diseases, there's a microorganism that's behind it, and that kind of caught on the most. Very recently, there was some information that the alpha-gal allergy might actually be protective in protecting people from getting one of these infections, because when they're bit by the tick, they have an itch response and they won't let the tick stay on them as long, and so it's less likely to transmit the disease. Similar to how we say sickle cell anemia carrier trait protects against malaria. And they thought cystic fibrosis carrier trait might protect against cholera or typhoid fever. So in disease, sometimes there's some beauty also. And this is the Lone Star tick. Does anybody know how you tell a Lone Star tick from other ticks? It's a cowboy hat. All right. Now we're on to Blake Shelton. Blake Shelton used to play college baseball. One time he had a home run in both games of a doubleheader. Now he's back home here in Fairbanks. He's teaching at the same high school that he once was a star at. What does he do at night? He likes to play softball because he's such a good athlete. He plays on 2 teams. One is a men's team. They drink beer, they goof around. Another's a co-ed team, and they're out to win. No beer allowed, no goofing around allowed. So he pops him an ice cold Coca-Cola, takes a drink, goes up to bat, hits a home run, circles the bases, sits back down. Next drink out of his Coke, but then timing is everything, they once said. At least the cowboy hat joke worked. He feels an intense pain in his mouth. A chill runs down his body like a shock wave, and then he starts to swell up a little bit. Yep, there was a yellow jacket in that Coke can, like they like to seek it out. But he's not sitting out from a bee sting. He's a great athlete. He goes back out to the outfield. He's running around, and lo and behold, just collapses. So they have to call the ambulance. He gets epi. He survives, but it was his yellow jacket sting that did that. So when it comes to stinging insects, there are a lot of insects that can sting, but there's 5 that we can treat. There's 5 that we can do something about. So if you're allergic to one of these, it's a very different process to be evaluated and treated. We have available extracts of yellow jacket venom, bald-faced hornet venom, yellow hornet venom, wasp venom, and honeybee venom. So if somebody is stung by one of these and has an allergic reaction, then there are testing materials and there are ways to treat them and try to make them not allergic to it. We start by defining the reaction as allergic or not. So a lot of people think if they're stung on their hand and their arm swells up, they must be allergic. The allergy textbook, we call that a large local reaction. You have to be stung and swell somewhere else off that extremity. An adult who breaks out in hives, that doesn't even, a kid who breaks out in hives, that doesn't even count as an allergic reaction, even though they had hives all over. So you got to get stung on your hand and have your throat close, or your face swell, or breathing problems, or get lightheaded or dizzy or pass out. You need something that shows systemic reactivity. Even violent, like dry heaving or stomach cramping or vomiting, can be a sign of anaphylaxis. But just swelling, even if it's dramatic, a whole sausage arm still counts as a large local reaction. Now, large local reactions are at a tiny, tiny increased risk of having a full-blown allergic reaction on subsequent stings, but not a high enough risk to warrant the testing and the treatment. So what do we do when somebody goes into the emergency room and they have an allergic reaction of some sort to a bee sting? They give them an EpiPen, injectable epinephrine, and they say, don't get stung by that bee again. And that's usually as far as it goes. Sometimes we get a referral for actual testing. But we like to make the analogy that giving somebody injectable epinephrine when they have a yellow jacket allergy is like giving somebody a fire extinguisher when you see sparking wires next to oily rags in the garage. You do nothing to prevent that fire. You're just ready to put it out if it happens. So there is testing which can determine true allergy to the 5 stinging insects. The way we do it is, if you have a reaction, we don't expect you to identify correctly the insect, because it's hard to tell a yellow jacket from a yellow hornet from a wasp sometimes. So we test for all 5 of the possibilities. And if you react to one, and we test by watering the venom down, I think the first one is 1, 2, 3, 4, 5, 10 to the 5th, 10,000 times. And we inject a tiny drop of 1/10,000th strength venom under your skin. And if you get a red itchy spot where we inject it, then you're allergic to it. A person who's not allergic shouldn't even be irritated by that watered down venom. So we test for all 5. If you react to one, we stop, but we continue with the others until we get to the full, not full strength, but 1/100th full strength, because that's the highest strength that won't irritate the skin of a non-allergic person. So we can define, are you allergic to one of them? Are you allergic to 2 of them? Are you allergic to all of them? And then you can be treated. Treatment is you come in and get shots of diluted bee venom, whatever bee you're allergic to, and over time, we increase it. Every time you come in, you get twice as much or 5 times as much or 10 times as much allergen as you did the week before, and eventually you're receiving an injection that's the equivalent of 7 to 10 bee stings and you're not reacting. It can reduce the risk of a reaction in somebody who had a near-death experience from a reaction down to about a 3% risk, but it never can turn it to 0. It never quite goes back to the normal risk. So that patient will always have their fire extinguisher with them, but they'll be at a greatly reduced risk of reacting if they go through treatment. If a patient does have a severe life-threatening reaction, those treatments would be considered indefinite, but eventually they're getting a shot of yellow jacket venom every 12 weeks, not every week. That's how it starts out. If you're just a regular Joe who maybe plays golf every once in a while, and you had a reaction where you had a little bit of an asthma attack but responded to epi, you would complete your treatment in 3 to 5 years. But the point being here is that there are a lot of people who know they're allergic to bee stings, and they have an EpiPen, but they never knew that there was a treatment for the condition. They think that they're treated when they have their EpiPen. So that's why that one is there. All right, that brings us to Bruce Springsteen. Bruce Springsteen's a 12-year-old little boy. His grandparents live in Alabama. They had just enough of these winters here in Fairbanks, so they moved down there 2 years ago. Bruce went down and spent 6 weeks with them last year. He had the time of his life. He just spoiled rotten when he was down there. He's getting to go back again this summer, and he couldn't be more excited, but he sure hopes Grandpa takes care of those ant piles in the yard, because last year they bit him all the time, and it would itch and it would hurt, and he doesn't want that to happen again. So he gets down there, and lo and behold, Grandpa finally did something that Grandma said he should do. He took care of those mounds, and there's none in the yard. Well, Bruce goes down to the playground to play kickball with the other kids, and then he doesn't stay too long. He found one of those ants crawling on him. He swatted it off, but he didn't feel so good. So he went home, And he told his grandmother he thought his asthma was acting up. They had to give him a neb treatment, and they were wondering, if he was getting a cold or something. They weren't sure what happened. Well, the next day, he had these marks on his arm. And Grandma thought, well, maybe he's got the chicken pox or something, and that was why he was needing his nebulizer. But no, those are the calling card of the fire ant. And he was having an allergic reaction. So fire ants were introduced to America through South America. They were brought over in soil that was put in the ballast of ships for weight balancing, and they came from Brazil to Mobile, Alabama. And they've made their way up to the Mason-Dixon line on the East Coast and a little bit up into California. And there's two main species, and you can be allergic to both of them. Their venoms are very similar. Their mounds are hard to miss. They are huge mounds, if you've ever seen those in the southeastern United States. The fire ant itself will bite you. And there's the map. It's where they are and where they could be. You see, they're not in Alaska. But again, this is more what we see when people vacation, or we have several military patients who reacted when they were stationed at Fort Gordon, and now they're here. But the fire ant will bite with its mandible and rotate its abdomen around and sting 3 or 4 times. I thought I had another picture of the arm to demonstrate that, but I guess I only had the one. That brings us to the last topic, and that's the sunshine allergy. So the beetles. Maria is a 30-year-old mother of 3. It's Memorial Day. She's so excited to go and see her oldest daughter play softball. All winter she had to go to boring Mighty Might hockey at 6 a.m., the only time they could get ice time. So she's got her checklist. She's got the cleats, the batting gloves, the orange slices, Gatorade, sunscreen for the little ones. Even the outfielder whose moms couldn't be there, she made sure she was sunscreened. But Mom forgot to put her own sunscreen on. Well, they went 3-0 in bracket play, so they're going to be in the winner's bracket tomorrow. But then, that night, Mom breaks out in this bumpy, itchy red rash. And she's like, oh no, this is horribly itchy. What did I do? Did I use new laundry detergent? Did I change my soap? Did I change my shampoo? Nope, she didn't do any of that. She forgot to put on her sunscreen. She's having something called the polymorphous light eruption, or PMLE. So when people say, I'm allergic to the sun, this might be the closest to that actually being true. And it's usually the UVA light, which is between 315 and 400. It's the invisible spectrum there. It can be triggered by UVB light. It can, in very rare cases, by visible light, but it's usually the UVA. So what it does is it transforms an endogenous photoantigen and triggers an inflammatory immune response, and you get this red, itchy rash. Why is this problematic? It stays around for weeks, sometimes even a month. And there's not much you can do about it. It's itchy, but it doesn't respond well to antihistamines. You can put steroid creams on it, but that only helps a little bit. You can give oral steroids, and that still doesn't help that much. So polymorphous light eruption, I've seen that many, many more times in 2 years in Alaska than I did in 20 years in Georgia. And it has to do with how our sun exposure is gone, and then there, and then intense. See if I can get the right one here next. Did I go right past Jimmy Buffett? How did I skip that many? So Jimmy Buffett's a 48-year-old man, and he's reserved 5 nights at an Airbnb in South Florida. He is excited. It's got its own swimming pool. It's right on the beach. And the selling point for him, poolside tiki bar. They get in late Wednesday night. He can almost not sleep in late enough to get up and cut limes for nonstop margaritas. But then, the next day he awakes with this blistery red rash, and he's absolutely miserable. He's like, did I get sunburned? And to some extent he did. So this is called phytodermatitis. It's a notoriously problematic for bartenders in areas like this because they're cutting limes out there in the sun, and there's a chemical in the limes and lemons that becomes a photosensitizer. It actually is not just an irritant but an allergen, and so that's not an uncommon thing. So again, a vacation rash caused by the UV light. Limes are the most notorious, lemons also, but it can be shown with celery, carrots, parsley, mustard, dill, and figs. If you were making a mustard mojito, maybe not. But limes are the most notorious. That brings us to the last scenario, Huey Lewis in the news. Well, Jimmy and his wife, the guy who just had that rash on his hand, they befriended the people next to him down from Minnesota. Kent, not Ken, Kent and his wife Marty. They're an older couple, and Marty sure likes to run off at the mouth. So by the end of the night, they know all of Kent's medical history, including the difficulty controlling his blood pressure. Well, the next day, oh wait, it's Marty's blood pressure. Marty wakes up and she is red and itchy. She's red and itchy. And I know Jimmy's hand was bad, but she's worse. Hers is much worse. And she has, this Huey Lewis news, I need a new drug. She is having a drug-induced photodermatitis. So there are certain medications that when you're on them, you're much, much more likely to become sensitive to the sun. And I've listed some of them there. Most notorious is thiazide diuretics, hydrochlorothiazide or HCTZ, being a very commonly used one. So that might be what you see the most. Antibiotics, including sulfa drugs. So the Bactrums and the Septras, doxycycline or tetracycline, probably the next likely. Non-steroidal anti-inflammatories, naproxen, even ibuprofen can do this. So if you have an out of proportion sunburn and you're taking something for your achy knee, it could be that you have become photosensitized because of that medication. And then antipsychotics, which that's when I had it. No, that's not as commonly used medicine. But those are the things we have to think of when we see these rashes. Are we dealing with polymorphous light eruption? Were there other things involved, like the bartender's hands, or are they on a medication that's made them ultra-sensitive? To be actually allergic to the sun in its own right is almost impossible. So take-home points. Your apple, peach, cherry allergy is really your birch allergy. We want to feed peanut butter to babies. We need to travel smart. We don't want to get stung by bees. We need to go to the beach for the entire month of May. Please use sunscreen and always let someone else make your margaritas. So sorry about my poor skills on the double keyboard here. I knew it was going to be a problem when we were setting it up. But any questions at this point? Yes, sir.
Yeah, I have a gluten sensitivity.
Okay.
Is there also a wheat allergy? Are those different?
Yep, those are different. So I flew past one slide where it talked about different types of food allergies. IgE-mediated allergy would be a wheat allergy. That's going to be common in a child with eczema. And there's actual anti-wheat antibodies. If you have a true gluten sensitivity, I still think there's a couple categories of that. But there's one called celiac disease. Right. And celiac disease is true gluten intolerance. And there's real repercussions if you continue to eat gluten if you have celiac disease. You can have higher risks of certain cancers and things like that. So that's a well-defined subset of gluten intolerance. But I have patients who don't have celiac disease, who feel bad when they eat gluten, and are gluten intolerant. So I think there's a spectrum of it, and there's a well-defined end to the spectrum, like I said, with known repercussions. And there's a middle to that, probably more people who are gluten intolerant and just feel bad, but don't have downstream repercussions. And then there's gluten and wheat allergy, IgE-mediated mechanisms for that. So you're somewhere on that spectrum, but you don't have celiac disease, you're saying?
I've never been told what I do. I think I was tested.
Right, you can be tested by a blood test to screen for that. If you're eating gluten, if you're already off of gluten, you can be a blood test to look for genetic markers, which would give a strong likelihood. If you feel better off of gluten and you have the genetic marker, that you probably have it. But ultimately, a diagnosis is made through a scope and biopsy. That's how a formal diagnosis of celiac disease would be made. I don't do any of that. That's GI. We screen for it, and if we find it, we send them to GI to get an ultimate or a final diagnosis.
However I test, I would not change what I am doing based on how I feel.
I have to tell patients that all the time. There's no better test than real life. That's why the ultimate test for these food allergies is we bring them in and they eat it and we see what happens. So testing can support a story, it can support a diagnosis, but real life or these challenges are how we make a formal diagnosis, absolutely. So yes, you're gluten intolerant, I believe you. Yes, ma'am.
How do you diagnose and then treat fragrance allergies?
Yeah, so there's very little you can do about fragrances or irritants, chemicals like cleaning chemicals, bleach smells, fragrances. Those are things that would bother anybody at high enough concentrations. So I always describe, if we put you in a phone booth and we pumped in some of that perfume that you might have to get out of there right away, but everybody will have to get out of there eventually. So only treatment for things like that is avoidance. So you have to go into the mall through the food court. You can't sit in the pew at church behind the lady who wears that certain perfume. You have to remove yourself from that setting when you notice it, but there's no real good testing. Now you can have contact sensitivity to fragrance mix. So when we deal with chronic rashes, there's patch test for fragrance. There's patch tests like there is for nickel and metal allergy. So you can be allergic to fragrances by that, but usually you have to demonstrate a rash to kind of have somebody think to do that test. So it measures kind of T-cell reactivity type of allergy, which is a different category of allergy than, say, a peanut allergy or a weed allergy, and different yet again from a gluten intolerance. So patch testing can identify it as a skin irritant, but as a respiratory irritant, again, real life, the story is true. If it bothers you to be around the bleach that they use at work, there's little you can do about that, and the little you can do to test to prove it. Yes, ma'am, the purple.
I follow up, this is something I developed later in life, same intolerance. I can't walk down the aisle with the clothes soap.
Mm-hmm.
I mean, and there's only one brand of clothes soap. I think this is something that needs legislation because the Febreze has
Febreze is
polluted our breathing environment indoors. And when I travel, I have to bring my own sheet, put it over the sheets, so I'm not touching or breathing the sheets or the blankets in the hotel. And that's my coping mechanism. But it interacts with the birch pollen allergy. So if I've suffered, then
right. So if you're already revved up allergically because it's springtime and birch is out, you have less reserve to give to the irritation of the fragrance.
And it worked the opposite way when I was out of town before I came home at peak pollen. And I had a really bad birch reaction for the first time because I didn't have my birch sap and it didn't come in gradually. And maybe it was just a really bad year.
Right. But so we use what we call the bucket theory of allergy for a lot of things. That individual things might not be misery producing or set you off, but each thing is like a rock in the bucket, raising that water level, and then it's ready to spill because you've already got rocks in your bucket. So that's kind of what you're describing. You've got your fragrances as a rock in the bucket, you've got your birch allergy as a rock in the bucket, and your bucket can't hold it when they're both there. And when you come back to peak birch season, it's different than the rock being in the bottom of the bucket. You're dropping the rock in the bucket, and again, the splash is happening. So the bucket theory, we use that a lot to try to explain things. But all I can do is sympathize with you. I can't, treat that. A lot of times the respiratory symptoms experienced from irritants are going to be upper respiratory tract. They're going to be more like vocal cord spasm. There's not as much actual inflammatory damage in the lungs. A lot of times, if you do pulmonary function testing on patients with irritant responses, they'll still have normal airflow in the small branches of the lungs. And so it suggests it's more upper airway irritation and vocal cord, which might feel a little scarier than the inflammation in the lungs. The old Dr. Dolan that I trained under, he used to tell patients that the good news is if you faint from this, your vocal cords will relax. And so that was his way of showing no empathy at all. Which he never showed any empathy. Yes, way back in the back.
So back to what everybody's talking about, perfume. Is there any treatment for a reaction to perfume that goes into is up here in the nasal cavities in the head. I mean, that's where it's more prominent.
Well, it's all one airway, so you're just having some mild inflammatory response there. It's usually not as dramatic as IG-mediated allergy. If we were to look in there, we would not see as much swelling. We would see maybe more irritation. There isn't a lot you can do. People who have chronic congestion from irritation like that, there is non-prescription nose sprays made from capsicum, like hot pepper type material. It doesn't burn when you spray it in there, but because it's more of an irritant response, you provide a controlled irritant response so that you're more tolerant of the one you don't control. So sinus plumber, sinus buster are the names those go by, and sometimes they can help by using up some of that reactivity already through the use of the nose spray. But there's not desensitization protocols. You can't flood that out of somebody. You know, it's a response that seems to heighten over time. And whether that's true reactivity of the tissues or if there's a subconscious kind of protective mechanism that the brain is employing because it doesn't feel good, that response becomes exaggerated over time. So there's little you can do but avoidance. I have a dictation phrase, .irritant, that just puts a paragraph trying to explain that to patients. It's frustrating for them, it's frustrating for me. I'd much rather be able to give you allergy shots and desensitize you or some sort of method for that, but there's little I can offer there.
Is there any treatment for the perfume allergies to give you the contact other than avoidance?
So same thing there. Contact dermatitis, contact allergy, there is one treatment, avoidance. Now if somebody is inflamed and irritated, we can use steroid creams and sometimes have to use oral steroids to quiet that down. But if they don't remove themselves or remove their exposure, it'll just come right back. It's the same type of rash you see in like poison ivy and poison oak. It's the same pathophysiologic mechanism when somebody's allergic to fragrance or somebody's allergic to nickel or somebody is allergic to some 32 character chemical in the diaper wipes or something.
Well, out of respect for everyone's time, I'd like to thank Tony for a fascinating talk.
I think